Welcome to today's webinar on disordered eating and GI, screening, assessment, and interventions with Beth Rosen. I'm Jocelyn, our registered dietitian here at Kiwi Biosciences, the company behind FODzyme, where we make digestive enzymes that target FODMAPs. Before we get started, I just want to cover a little housekeeping. So today's session is being recorded, and we'll share a link to the recording in an email tomorrow. The live webinar has been approved for 1 CEU by CDR, so that email tomorrow will also include a link to download your CEU certificate. We'll also be submitting the recorded session for approval by CDR for a recorded CEU, and you'll be able to download that certificate after it's been approved. We're also excited to offer a self-directed CPD form and certificate of completion for our international participants. In addition, I just want to orient you a little bit to our platform. So at the bottom of your screen, you'll see a comments box and a Q&A box. So please just try to keep your comments to the comments and the questions in the Q&A so that we can keep ourselves organized. We'll get to as many questions as we can at the end of the session. And with that, I'll turn it over to Claire, our co-host from NERVA, who will introduce herself and Beth.
Thank you, Jocelyn. My name is Claire. I am the research lead at Mindset Health, the company behind NERVA. NERVA is a gut-directed hypnotherapy mobile app for IBS patients. I am really honored to be able to introduce Beth Rosen for this amazing webinar that she's doing. Beth is a weight-inclusive registered dietitian specializing in GI nutrition and disordered eating. She has been working in the field of nutrition for over 27 years and has a virtual private practice. Beth helps clients find relief from digestive disorders such as IBS, small intestinal bacterial overgrowth, gastroparesis, celiac, and reflux. Beth is also the chairperson of the Dietitians in Gluten and Gastrointestinal Diseases subgroup of dietitians in medical nutrition therapy, dietetics practice group of the Academy of Nutrition and Dietetics. She is also the director of nutrition and dietary services for GI On Demand, providing integrative GI virtual care and support to patients. And that barely scratches the surface. Beth is wonderful, and I'm very excited to introduce her and to let her take over for this webinar.
Thank you so much. That was so kind of you to introduce me. Hi, everyone. This is a webinar on disordered eating and GI screening, assessment, and interventions. We're going to scratch the surface today. There's so much to talk about, but we'll start here. Here are my disclosures. And the agenda for today, we'll start with an overview of disordered eating and eating disorders, the diagnoses, as well as the difference between the two terms, and talk about tools for techniques for assessing eating disorders. And I'll give you some examples of some interventions for treating eating disorders when you've identified patients with eating disorders via 2 case studies. So I'm hoping we have lots of time for that. So let's look at the difference between normal eating, disordered eating, and eating disorders. Now, a major characteristic of normal eating is that eating fluctuates and should not result in nutrient deficiencies or weight changes that don't come back to homeostasis or balance in the absence of an illness or a life issue. And a person with normal eating should be able to eat enough to get adequate nutrients and calories to meet the needs of their body and their lifestyle. Feel good or neutral about food without categorizing food as good or bad or healthy or junk or any other diet words that may come up. Be able to eat intuitively, which means to listen to their body's cues for hunger and fullness, but also eat for pleasure and feed their souls in addition to feeding their bodies. And they should spend very little time, maybe 20% or less, thinking about food or focusing on meal planning. And so it shouldn't dominate the day. Disordered eating is characterized by holding beliefs and attitudes towards food that lead to guilt and or anxiety. And they spend a lot of time thinking about food and meal planning, bargaining with diet rules, having concerns about their size and their shape, or the changing of their size depending on what their food choices are. And it's important to note that When many in society have similar unsubstantiated beliefs about food, normalization of disordered eating can be deemed normal even though it's disordered. So, for example, a widely held belief in the US is that carbs are bad. And I put those in quotes for those that can't see me. But as healthcare providers and trained dietitians, we know that our bodies and our microbes need carbohydrates to thrive and provide us with nutrients and prebiotics and even enjoyment of food. So that's an example of a disordered eating pattern that's been normalized by society. This group does spend most of their day thinking about food and meal planning and worrying about the consequences of those. So, eating disorders, by definition, are diagnosable psychiatric illnesses marked by ongoing disordered eating behaviors and thoughts and beliefs that impact not only emotional and physical health, but also psychological health. Quality of life is definitely impacted. And there's usually a lot of black or white thinking with very little room for shades of gray. Eating disorders are diagnosed by mental health providers, and they use something called the Diagnostic and Statistical Manual of Mental Disorders, known as DSM-5. It's the 5th edition. And it's not uncommon for those diagnosed with eating disorders to have other psychological co-occurrences, things like anxiety or obsessive compulsive disorder. And for some, there's also a genetic component. So here are some facts and statistics about eating disorders. Again, I'm based in the US, so that's where this data comes from. But the US isn't the only country where eating disorders are prevalent. You'll find them in any country where there's a society that reveres thinness or considers thinness to be healthy, and where bias exists towards fat bodies. The first fact here shows that there's a discrepancy between who experiences eating disorders and disordered eating and who gets diagnosed. So although 1 in 10 folks are diagnosed with an eating disorder, up to 50% of Americans have some form of disordered eating. And eating disorders are really dangerous. They are the second leading cause of death from mental illness that can be caused by mental complication from the eating disorder or by suicide. The first cause of death is opioid use disorder in this country. And it's also really expensive to get treatment. So the average cost is $80,000, and very few insurance companies, panel providers, or cover what's needed for people to really heal and get into recovery. And in this country, there are only 10% of people who can receive treatment. There are actually only 5,000 beds available in residential treatment. There are different levels of treatment, residential being the second highest. First is inpatient, and then residential, and then they step down to what's called partial hospitalization program, which is most of the day, but not someplace where you live, and then to intensive outpatient, which is a couple of times a week, a few hours, and that's done, also either in a center or virtual, but just part of the day. And then the last would be outpatient, which is the work I do with folks who have eating disorders. What you'll see here is that one person every 52 minutes dies from an eating disorder. So you can see that this is something that we need to make sure that we're taking better care of these folks so that this doesn't happen. And this last one shows that up to 98% of folks with eating disorders will develop functional GI disorders. And I'll show you that possible mechanism in a minute. But I just want to show you a few more facts and statistics. This is what eating disorders may look like when working with clients in the GI population. Eating disorder prevalence is up to 24% in general GI practices. So if you work with GI patients, you are working with people with eating disorders. I'm going to repeat that a lot. I think it's important for us to understand that in most cases, the eating disorder comes first, but there are some cases where GI disturbances can fuel the disordered eating, as is the case a lot in inflammatory bowel diseases, where we see a prevalence of about 10% of folks with ARFID, which is avoidant restrictive food intake disorder. And I'll explain more, get more in detail about that in a few minutes. But the reduced intake can impact motility and fuel a cycle of disordered eating when people are worried that food is causing symptoms, and so they take in less food. The pathology of the connection between DGBIs and eating disorders are only partially understood, but if we were to start at the top left-hand corner, we can see this potential cycle where eating disorder behaviors impact the GI tract, and those include things like vomiting or laxative abuse or even restrictive intake. And then malnutrition can occur in eating disorders, and that leads to electrolyte imbalance and metabolic myopathy. And then the gastric motility, intestinal transit time, and gastric emptying can be impaired from that. And so what can happen is that food can just sit in the gut and not move fast enough, and that can produce signals of gastric distension and fullness, and that can create a perception of this fullness that may not exist. So this person can become malnourished because they're not actually getting enough to feed themselves. And then finally here, changes can occur in the microbiome and provoke GI symptoms, as well as the ability to regulate hunger and fullness. So a lot of people, when they fall into disordered eating and eating disorders, lose those cues for hunger and fullness. And then the cycle can start again. So we don't know a ton about the connection here, but what we do know is that functional changes along the gut-brain axis are worsened by the changes to the microbiome and from undernutrition. And impaired GI motility appears to be secondary to malnutrition from muscle wasting, from the lack of neurotransmitters. So for the most part, we tend to see GI conditions in folks with anorexia, bulimia, and binge eating disorder. So I'll share that also in a minute. But folks with ARFID tend to have a lower rate of GI co-occurrences. So typically, ARFID may come first before the GI for some folks. And the reason why ARFID has a lower rate of co-occurrences is because there's no body image aspect to it. So actually, ARFID is it's this different beast that exists with GI, and it's believed to be due to this lack of focus on body image or a need to be thin. Okay, so we're going to take a poll, and the question is, what percent of people with eating disorders are considered underweight by BMI standards? You're not allowed to Google. I see in the comments, a lot of people know the answer to this. So yes, the answer is A. Only 6% of folks with eating disorders are considered underweight by BMI standards. So what that means is that 94% of people remain above that cutoff. So what the takeaway here is that you can't tell an eating disorder by the body that contains it, which is why we need to screen everybody. So let's talk about types of eating disorders. And we'll go over just the most common ones. Really, this is like a refresher course if you've had these before, but just to touch on the different ones that you might see in GI. Anorexia nervosa is this first one, and it's probably the eating disorder you think most about when people talk about eating disorders. And it's characterized by an extreme focus on weight loss, control over food, and body dysmorphia, which is a belief that your body looks different than it does. And the behaviors lead to malnutrition and starvation. And currently, the severity of the eating disorder is based on BMI. The DSM-5 has been around for a while, and they use BMI as a measurement of low body weight. But recently, the American Medical Association acknowledged that there's an inaccuracy and a racial history to the tool. So I'm hoping that in the next iteration of the DSM that they remove that, because another classification of anorexia is atypical anorexia, which has the same characteristics as anorexia without the low BMI. So since 6% of people have the low BMI, most people with anorexia fall into the atypical anorexia space. And there are two subtypes of anorexia. There's the restriction type, and the binge purge type. And the binge purge type is that during the past 3 months, the patient would have engaged in recurrent episodes of purging or binging and purging. And that looks like self-induced vomiting, misuse of laxatives, the misuse of diuretics or enemas. And this condition is very common to have coexisting psychiatric conditions. Bulimia nervosa is the next one, and this one is characterized by a preoccupation with weight and size, but restriction is followed by binging and purging. And I want to note that the DSM-5 is limited and does not categorize everybody neatly into a category when they're diagnosed with an eating disorder. So atypical anorexia with binge purge looks a lot like bulimia nervosa. Again, inappropriate compensatory behaviors are taken up in order to avoid weight gain. Excessive exercise is one of them as well as fasting, which I didn't mention before. And I think it's important to also acknowledge that when people binge, I know it's a common term a lot of people will use in normal conversation, but a binge looks like eating more than would normally be eaten in 2 hours, feeling a lack of control, usually feeling sick after, and big feelings of guilt and shame after eating, and eating in secret. Those are some of the common things there. So that is bulimia. The next one is binge eating disorder. And binge eating disorder has the binging component without compensatory behaviors as a means to a purge. So binge eating disorder is the most common type of eating disorder, and it's more common than anorexia and bulimia combined. And these folks can experience weight gain or fluctuations in their weight, and they can have an element of restriction too, or not. And lots of times, folks who have binge eating disorder have either a trauma, or they have a history of trauma, or a history of chronic dieting, or both. Okay. Avoidant restrictive food intake disorder, aka ARFID, is the only eating disorder that we know of without a focus on body size and shape. And it can be characterized as a lack of interest in food or fear of food, as we see with people with IBD. The fear can also stem from consequences of eating, so a fear of choking or having experienced this before. So things like choking, nausea, vomiting, or an allergic reaction to food can also bring it on. But it can also be brought on by food poisoning or a GI issue. And it can result in malnourishment and impact the quality of life and social functioning. Now that we have a basic idea of the most common eating disorders that we'll see in our patients, let's look at how we might identify them. Again, we don't diagnose as dietitians or healthcare professionals that aren't in the mental health space. But if we suspect that there's an eating disorder or disordered eating, we can refer to mental health professionals for diagnosing and counseling. During an assessment, these are some things to look out for and ask about. Well, BMI, of course, is one of those things. I'm not big on using that as a tool, but one of the things the DSM-5 does is consider the severity of anorexia based on the BMI. So a BMI between 15 and 17% would be considered a severe form of it. But this is, again, only seen in a small population, and I can't stress enough that we need to look past body size and see what else is going on with the people. We might see fluctuations in weight, like a progressive loss or an inability to gain weight back after a loss. It's important also to look at menstrual status for those with a uterus and of age to menstruate to see if it's irregular or if there's amenorrhea. Of course, bowel habits. I think we all ask about bowel habits, but what we see in anorexia quite often is severe bloating and long-term constipation. Of course, we can ask about eating patterns and food rules and what diets are followed, or if there are food groups or foods that are eliminated or avoided. if you have a good relationship with a patient, you might be able to delve further and ask questions about things like body checking. And body checking is looking in a mirror or pinching parts of the body, measuring with a measuring tape, or weighing multiple times a day. It's something that fuels that eating disorder voice in the head to keep on the disordered behaviors. And of course, body dissatisfaction dominates thinking. So you may hear comments or where they put their bodies down. And the preoccupation with weight and shape is pervasive. So they may mention parts of their body they don't like, or that things are too big. And self-esteem is strongly influenced by weight, shape, and control over food in this group. And what you might also see is a co-occurring past or present psychiatric diagnosis. In my practice, I see a lot of general anxiety disorder. I see a lot of OCD, a lot of ADHD. You might see that too. For the very thin folks who don't have a lot of body fat, they may have cold intolerance. So it may be, a summer like we're having here where it's, the world's on fire and they're wearing sweatshirts because they're cold. So you might see that in some folks. And also brittle hair and nails, you may notice a thinning of hair and broken nails. That's something you might notice by looking at somebody. And one last thing to mention would be sleep issues. People can have trouble sleeping when their brain is not well fed. So that's another thing that you can look for when you talk with them. BMI is here again, but I think more than that, we can look at their bowel habits, if they're using laxatives, what their relationship is with food, their relationship with exercise. Questions about exercise can be, do you exercise? How often do you exercise? Do you take rest days? Do you exercise when you're ill? Those kinds of things. There's usually a very strict rule around exercise, and it's done quite often. On appearance, you might notice swollen glands, or what some people refer to as chipmunk cheeks, so swollen salivary glands or dental issues from purging. And they may share that they have, thoughts about their weight and shape. It's important also to note that not everyone will have every characteristic, but knowing what they are might be able to cue you into some of the maladaptive behaviors that you see. So many people with binge eating disorder, as I said before, also restrict. And as a result of the restriction, they binge. And like people with anorexia and bulimia, they will also have body image issues. But besides body image concerns, people with binge eating disorder can use binge eating as a coping mechanism for past trauma. So while body image will certainly still play a role, it might also be a coping mechanism for something not related to the body. When you have these conversations, they should not be participating in compensatory behaviors because that's the differential for bulimia. And they may have lots of guilt related to food and food rules, or a long history of chronic dieting. And then with ARFID, you want to make sure that they don't have a poor relationship with their body, or their actions aren't related to their body size, because that's the differential between ARFID and anorexia. And there is a fear, but it's not necessarily how the body would change according to food, but maybe what might happen to the body if that food is taken in. Again, it could be, the vomiting, it could be a fear of an allergic reaction or some GI issue. This can be brought on by a history of trauma. It can be brought on by food poisoning, all of those things. For those who are on the autism spectrum disorder, this is also a common eating disorder, and their issue is usually related to the texture or smell or taste or even temperature of the food itself, or a lack of interest in eating. So you're going to see this, across GI, but also with folks on the autism spectrum. So if you see that in your practice, you may see ARFID more commonly. There are also some tools you can use for assessment to really know for sure whether or not someone has an eating disorder. And the most common tool used is a version of the eating disorder examination. This first one, the EDE, is an interview that is done by a clinician that focuses on 4 subcategories that include restraint, which is restraint is having a food rule, but possibly breaking it. So saying donuts are bad, and I'm using quotes again, and then you eat the donuts and then you feel badly about the donuts. So that's restraint, where you still have the rule, but you're not restricting, so you ate it. Also, a concern about eating and shape concern and weight concerns. And the Eating Disorder Examination Questionnaire, or the EDEQ, is a self-reported version of the EDE that's an interview that's done by a clinician. There's 28 questions on there, and there's a scale for scoring. Lots of times it's self-administered, but done with a clinician around so that they're available to answer questions. There are links here to them, but if you Google them, they're free to use. This next tool is the Eating Attitudes Test, or EAT26, and this tool doesn't assess for eating disorders. You can't get a diagnosis out of this, but what it does assess for is an eating disorder risk, and it's an appropriate tool to be used in healthcare settings, but also at fitness clubs or in schools or even with sports teams. And it's intended for adults and adolescents, and again, self-administered and available free online. And it could really cue you into some maladaptive eating behaviors if you were trying to capture that data from everyone who walked into your office or onto your screen. This next tool is called the Eating Pathology Symptoms Inventory. And this is called SB, and it can generate an eating diagnosis based on the DSM-5. And one thing I probably should be real clear on is that none of the tools I've mentioned so far are validated for people with co-occurring GI issues. So while this is a great tool and could potentially diagnose somebody, one, that's not our job. But two, if somebody has an eating disorder and a GI disorder, then there really is not there aren't many tools available to us. There's one, and I'll share that with you. But this one has 8 subscales and goes through a lot of the different behaviors that people with eating disorders experience. The SCOFF questionnaire is a quick 5-question tool that was developed in the UK, but only screens for anorexia and bulimia. And the acronym is meant to help you remember the questions. So SCOFF is, do you make yourself sick because you feel uncomfortably full? The C is, do you worry that you have lost control over how much you eat? The O is the UK part, which is, have you recently lost more than 1 stone, which is 14 pounds or 6.35 kilograms in a 3-month period? The first F is, do you believe yourself fat when others say you're too thin? And the last F is, would you say food dominates your life? This is also readily available if you Google it to be used. I think it's a limiting tool. But it's still a tool nonetheless. So if you have nothing else and you remember the SCOFF questions, you can ask them. This is our newest diagnostic tool, and one that's used specifically for ARFID, but should be used along another tool to rule out other eating disorders, because it doesn't in its process rule out the other ones. And it has 3 subscales that focus on picky eating and appetite and fear. And again, this is something we commonly see in IBD. And for them, they have some dietary behaviors that become altered, either because they avoid food triggers or they're worried about inflammation and trying to control it, not usually based on a weight concern. This is the one tool we have that is validated for GI issues, but it's only used for people with celiac disease. And this is the Celiac Disease Food Attitudes Behavior Scale, or CDFAB. And it's an 11-item questionnaire that assesses attitudes and behaviors towards food. So it's not a full diagnostic tool, but it lets you know whether or not there are thoughts and behaviors and attitudes towards food that are disordered. And then there are some tools that are not necessarily diagnosing or assessing risk, but a tool like this, which is the SATR Eating Competence Inventory. This one is a validated tool from Ellen Satter, and it focuses on 4 subscores, and it really talks about competence versus maladaptive eating behaviors. So this is one that I actually use in my practice, and anyone who walks in my door gets screened. And I have yet to find a big handful of folks who don't have maladaptive eating, because most of the people I see either have GI issues, eating disorders, or both. But I find it to be an interesting tool to use. And if a tool feels clumsy, then you can have a conversation with your patients and be curious about their relationship with food and their body and compensatory behaviors. And as of 2015, the prevalence of disordered eating and eating disorders in patients with GI disease is high, ranging between 5.3% and 44.4%. And this can make it difficult to treat a GI condition when there's a coexisting eating disorder. So if you take one thing away from today, it should be this, which is always treat the eating disorder first before making any dietary changes to the GI disorder. So there are ways to treat an eating disorder without exacerbating the eating disorder symptoms. Treating someone with an eating disorder is truly a life or death situation and needs urgent support. There are still some things we can do without changing their diet. So let's look at those. There are so many tools, and these are just a few, but these can be used concurrently with eating disorders. This is not an exhaustive list, just a couple that I had come up with. The first category is cognitive therapies, and under there is cognitive behavioral therapy, and you can refer out to a mental health professional that knows how to do this. There's also gut-directed hypnotherapy, and you can refer out, or you can use the Nerva app, which has really good data to show that it improves functional GI scores. And I've had good success with it with my patients. They seem to really like it. It's not hard to use. Takes about 15 minutes every day. And it does definitely help. And it can help with some of those co-occurrence of the psychiatric disorders where maybe there's some anticipatory anxiety related to their GI issues. Behavior changes can be made too. So creating a toileting regimen where maybe they're drinking a warm liquid in the morning and using a stool or squatty potty in the bathroom. Sleep hygiene is important. There's new research that shows that the circadian rhythm is impacted by the microbiome and vice versa. So that's something that they can do, is make sure they're getting enough sleep. Wearing loose clothing around the abdomen can help folks who have reflux, or folks with IBS who have really sensitive stomachs, and just make them feel comfortable regardless. Smoking cessation, I just put that in everything because I think that would help with a lot of things if we didn't have cigarettes around. But then you can also include movement, and I have a double asterisk there because for some folks that might not be appropriate, because if they're using it as a compensatory behavior, their therapist might recommend that they stop exercise. But for those that are not using it as a compensatory behavior, movement can help those with gastroparesis and reflux right after a meal, just sort of help the food move along by moving a little bit. And this last category here is supplements and medications. Certainly prescribed medications by physicians are always helpful. Digestive enzymes like lactase and alpha-galactosidase and FODzyme, that includes both of those, plus fructan hydrolase, which covers the majority of the FODMAPs. So without having to do the diet, taking the enzymes with the food has been really helpful for so many of my clients, myself included. Chewable simethicone, which is Gas-X, can help with gas. Stool softeners for those who are constipated. Enteric-coated peppermint oil is an antispasmodic. Laxatives, again, the AGA and the ACG came together and released a guideline recently about how to treat constipation. And one of the things that they recently included was stimulant laxatives, and those wouldn't be good to use with folks with eating disorders who have compensatory behaviors of purging. So certainly using other forms of osmotic laxatives might be helpful, but not the stimulant ones. And last but not least is fiber supplementation, whether that's psyllium husk or guar gum, if it's for the prebiotics or the bulking of the stool. There's so many things that that we can use. And one silver lining to all of this is that in many cases, when the eating disorder is treated, the functional GI issue will resolve more quickly. So, if we can work not causing more harm by not introducing more restriction, then they may be able to go through recovery a little bit quicker, a little bit safer, and feel better with their GI conditions. Okay, so I have a couple of case studies to share with you. And these are actual clients of mine. I just changed their names, but the rest of it's the same. So let's start with Jane. Jane is was a 22-year-old woman. She's now, I think, 26. Diagnosed with gastroparesis. She was diagnosed with anorexia in high school, with periods of extreme restriction, that's what she reported, and purging via vomiting, laxatives, and exercise. She has a history of reflux since she was 12. She shared with me that she's been a very nervous person her whole life, but she was diagnosed with general anxiety disorder, OCD, and ADHD, chronic constipation, and low blood sugar in the past. And her symptoms included constipation, belching, early satiety, nausea, regurgitation, and a fear of food. And she reported an increased anxiety around eating foods that might trigger constipation or a flare of her GP. And she was diagnosed with the gastroparesis and began limiting her intake to applesauce and soup broth, which was less than 1,000 calories per day when we counted it up. And that led to a backslide in her eating disorder recovery, or not even recovery, but I think it increased her eating disorder behaviors, because I don't think she really did much work before we started talking about it. But she was open to eating more, but she did worry about gaining, quote unquote, too much weight. So there was a body image issue there. Her meds included Celiac, birth control, pantoprazole. She was using IBGard and Gas-X and Miralax, and she was taking a probiotic. She was also working with a fitness instructor at the gym who taught her to, quote unquote, eat clean. And she was on a diet of 140 grams of protein, 60 grams of fiber, and avoiding fat, and working out 6 days a week. And she was not currently working with a therapist or a gastroenterologist. And her 24-hour food recall from the day before included coffee with Miralax and oat milk, banana, tuna salad, potato chips that she would crunch up into little bits. Sometimes people who have anorexia do something called microbiting. They take little bites or they break up their food. And so potato chips were pulverized. A little bit of chocolate, strawberries, lots of popcorn, another tea with Miralax, and meatloaf. She also reported that she eats a whole bag of popcorn when she eats it. And so she was currently moving her bowels 3 times a week, and she reported being a number 1 on the Bristol stool chart. So the intervention we started with was to treat the eating disorder before the GI interventions came into play. So I started with something called the rule of threes. And if this is not something you're familiar with, briefly, what it is a guideline for how to choose food and plan during the day. So it's 3 meals a day, up to 3 snacks a day, eating at least every 3 hours, unless you're hungry before, but not going past the 3-hour mark, with at least 3 components to up to 7 components of foods. And if you're a dietitian, you know your components. It's fat, protein, carbohydrate, fruit, vegetable, dairy, and fun foods. And I always include fun foods with my clients, eating disorder or not, because I want all foods to fit into their life. So that becomes part of their choices. I asked her to reduce her insoluble fiber intake, but only after she would do some what we called curious observation. So she agreed to keep a food and symptom and bowel log. And then if she noticed after eating the popcorn that her symptoms were exacerbated, then she agreed to reduce her popcorn intake and add something else instead or in addition to the popcorn. And she agreed to that. And I decided to meet her where she was, so I would offer challenges along the way. I referred her to an eating disorder informed therapist and a gastroenterologist. The therapist, I I happen to have a group that I refer back and forth to because I've gotten to know them. When you create a team for someone, you get to know the people in the team. And then when you do have a new client who might not have the proper team members, then you can quickly refer. So this is somebody who I knew already. I knew was eating disorder informed and trauma informed, and she was referred to this person, and they worked together for a long time. So I've been seeing this client for over 3 years. I actually still see her, not as often as I used to, but we catch up every month and check in. And this was our first month of follow-ups. She was able to eat 2 meals and 1 snack regularly, and over time, she was able to get to more meals and snacks. She did end up reducing her intake of popcorn because she noticed that she moved her bowels more often and had fewer days with severe gastroparesis symptoms. She ended up stopping the IB guard because her symptoms had dissipated and began working with a therapist that I recommended. And then we spent some time brainstorming some foods that she would like to include that she thought she might tolerate. And the list she came up with was shredded chicken, nut butter, juice, smoothies, blenderized soups, banana bread, crackers, and tzatziki. I never hand out a diet. I always ask clients how they like to eat, and then we find foods within there. Me knowing what might not hurt with gastroparesis, and her knowing what her preferences are, and then that's how we can create a list. I don't share, you can't have this, you shouldn't have this, because if she thinks she can tolerate nut butter, then I'm going to let her eat nut butter. And if she doesn't tolerate it, we'll know from her log and she'll stop. But everybody's so different that I think it's important to make sure to have those conversations about food and not just give a handout. She did have a few instances of vomiting that she believed was due to anxiety and the gastroparesis. And upon further discussion, one of the things we found was that she could vomit voluntarily just by contracting her abdominal muscles. So if she was frightened that the food in her stomach was going to lead to symptoms, or that the food in her stomach was going to lead to weight gain, she purged. So that she ended up realizing very quickly that that wasn't working for her anymore. Once she understood the difference between vomiting because it happens from nausea and sometimes with gastroparesis, and vomiting as purging. She did meet with the gastroenterologist that I recommended, and he prescribed her Linzess and Motegrity. And currently, she stopped purging soon after our second session. She was retested for delayed gastric emptying a year after we started working together. She really wanted confirmation to see if it had gone away. And when she tested, she was at 19% at the end of the 4 hours, and she was thrilled. So she was gastroparesis free at the moment, which was great. She currently eats meals and snacks regularly. She goes out with friends and families without issue. She no longer restricts. She eats from all the food groups. She can actually eat insoluble fiber foods now pretty easily, popcorn and salad. She still works with the eating disorder therapist and the gastroenterologist. And she still has her coexisting issues, but she doesn't use eating or purging as compensatory behaviors. And she works with her therapist and a psychiatrist for med management. And she's still on the Motegrity. She's tried to come off a few times. It just brings back constipation. So she's staying on it. And that is Jane. So she is in a great place, both in her recovery and with her gastroparesis, and with her constipation as well. Okay, so this next client is Keisha, and she's a relatively new client to me. And it's important to note that she has not vomited since she was 7, but it's a major fear of hers, and now she's 18. She was diagnosed with ARFID at 10, and she was also diagnosed at 12 with anxiety and OCD. And her food avoidance started as a result of medical anxiety. She was always afraid to go to the doctor, if she needed a test, if she had to go to the dentist. And she was afraid that she would get sick and vomit. And she did once when she was 7. And the fear started when she was 6, but she hasn't vomited since. And about a month before we started meeting, she got food poisoning, did not vomit from it, and it increased her medical anxiety. And then she was already scheduled to have her wisdom teeth extracted, and she had such a worry about that her thought was that the food poisoning and the worry about the wisdom teeth extraction kept the GI symptoms persisting. And those included diarrhea, abdominal pain, and cramping. And she reported that this led to food restriction. And because the symptoms were persisting, she saw a PA at her gastroenterology group who gave her a handout for the low FODMAP diet. She found it confusing, so she scheduled an appointment with me, and she's been avoiding going out with friends for fear of fecal incontinence, which she's never had. And her meds include dicyclamine 3 times a day before meals, which is an antispasmodic, amoxicillin still from the dental surgery, some of her psych meds, and a probiotic. She's not concerned with her weight or shape normally, but she lost 10 pounds due to the food poisoning, so she's worried about her health from the loss of weight. And her 24-hour recall includes Ensure, which she adds in when she does have medical fears because she feels like that's a safe food for her, half a banana. Typically, she has a turkey sandwich on white bread and cheese and mayo, but this day she had the leftovers from the night before, which was chicken and rice and mushrooms and broccoli and cauliflower. You can see all those FODMAPs in there. She had a snack of peanuts and Jell-O she's been having every day for years. And Cheez-Its as well. For dinner, she had potato skins with cheddar and bacon bits, and then later on onion dip with potato chips, and she drank some water. She believes that garlic, onion, cauliflower, eggs, and some dairy are trigger symptoms after reading the handout that she got from the PA, but she decided not to eliminate them because she knows herself, and she said that she would never reintroduce them. And she's been working with her current therapist for 3 years, who she trusts. And she and her mom took an IgG food sensitivity test years ago. So she still avoids many of the foods on that list, even though she never had GI symptoms from them. So the intervention we went with, if you've watched my recent webinar on the low FODMAP diet, I did highlight that the low FODMAP diet is not indicated for people with disordered eating or eating disorders. And there are alternative dietary and non-diet interventions. So I explained that to her and that we weren't going to go on a restricted diet, and she was thrilled. And then I gave her some education on the use of digestive enzymes and on using a prebiotic supplement every day for 4 weeks. And data shows that intermittent prebiotic fiber supplementation improves microbiome diversity, and it's been shown to be very effective. And then I also recommended L-glutamine supplementation for 8 weeks due to the fact that she had the food poisoning. And at the recent Digestive Disease Week in May, Dr. Lin Cheng from UCLA discussed the use of L-glutamine supplementation to improve intestinal permeability that may translate into improved symptoms management. And so I offered this as a treatment because it's deemed not harmful and it may actually improve her gut health. So we're going to try it. We worked on increasing her food repertoire, or we'd like to work on increasing her food repertoire and reduce the dependence on Ensure as time goes on, and also dispel food myths. So the IgG test, we talked about how that's not an accurate test for GI symptoms. We talked about some foods that were on the low FODMAP diet that she enjoys and doesn't feel symptoms from. So we talked about those things. She was also willing to keep a food log that included her symptoms and her feelings, since a lot of this is related to her anxiety, and a bowel habit log. And we discussed the use of gut-directed hypnotherapy, and she was open to it and wanted to talk to her therapist about it. And then one of the things that she mentioned was that her quality of life was being impacted because she wasn't getting to spend time with her friends because she worried that she would have fecal incontinence, and that's not how she called it, but that's what it is, while traveling to see them. So we talked about buying a camping toilet to keep in her car as a way to just know that it's there. And probably once she knows it's there, that anxiety will go away or lessen, and then she would feel free to go see her friends again. So currently, she is using enzyme supplementation, and it's helping. She started both the prebiotic and L-glutamine and is tolerating both. And she's keeping a log. and she was able to see that her GI symptoms were correlating more to anticipatory anxiety than to food. And she notes that she did have symptoms when she forgot lactose with ice cream, which that would happen to me too. So I get it. She discussed using the Nerva app with her therapist, and her therapist was all in, but she hadn't started yet. We're really new to working together, and she is going to work this week on increasing her food repertoire, starting with eggs, by having them in recipes like baked goods. She likes those, before trying them as just scrambled. So some takeaways from today: if you work with GI patients, then you work with people with eating disorders. Please remember that, and do your best to screen everyone for maladaptive eating patterns so that we don't cause more harm. Treat the eating disorder before treating the GI disorder. And we don't know what we don't know, so if you're not trained in eating disorders and GI, refer to somebody who is in the one that you're missing, or get training and so that you can treat both. And also, what's key is creating a collaborative, integrative team for your patient. So finding or including their therapist, their pelvic floor physical therapist, their doctor, their dietitian in on how you're taking care of this person so that they can heal and everybody can be on the same page.
Thank you, Beth. That was a fantastic presentation. Truly, you're such an expert.
Yes.
Well, thank you for sharing your knowledge with all of us. We do have some great questions, so I'm going to have us start answering this first one from Jessica, who asks, for potential trigger foods, what time frame do you give people for the lag between eating and the symptoms?
Good question. Anywhere between 4 hours and 18 hours. So I would say lactose you feel pretty quickly, and that's the 4 hours. 18 hours for somebody who might have constipation, maybe on the short side. Some people might take longer, but remember the food has to get to the large intestine to ferment. So it takes some time to get there, and then the fermentation has to occur, or the food has to get there, or not the food, but the molecules have to get there, the chyme, all the leftover parts, and then the microbiome has to go to work on it, or water has to be drawn into the colon if it's a large molecule like excess fructose. So it takes some time. I'd say average 4 to 18 hours.
Great, thank you. That's really helpful. Here, our next question, I might actually have Claire answer for us. Emily asks, what is the name of the gut-directed hypnotherapy app? What's the cost? Is it appropriate for children, adolescents, and adults?
Yep. The gut-directed hypnotherapy app is called Nerva. The cost is $150 for patients, $150 US for patients, and that gives them a year's access. And then in terms of it being appropriate for children, it's been studied in 18 years old and up. So that's what it's most appropriate for.
Great. Thank you, Claire. Here we have another one from Deb asking, which digestive enzyme and prebiotic supplements do you recommend, Beth?
So for digestive enzymes, I recommend Fodzyme. I actually do, and I'm the guinea pig, and I use it all the time. And I find that it works. But I will also recommend just generic lactase for people who have issues with dairy, digesting dairy. Because Fodzyme can be expensive for some folks, and lactase is really cheap. And if it's only dairy, then sometimes I recommend that. And I'll also recommend alpha-galactosidase, which is what's in Beano, separate if they're just having beans and lentils. But again, both of those things are in Fodzyme, so plus another enzyme which helps break down fructans, which are in wheat, rye, barley, garlic, and onion. So the majority of FODMAPs are covered by Fodzyme. So that's what I typically recommend. And then for prebiotic supplements, I typically go with partially hydrolyzed guar gum as the ingredient. And the three I recommend are Regular Girl. And then Sunfiber makes Regular Girl, but also Tomorrow's Nutrition makes Regular Girl, but also has a product called Sunfiber or Tomorrow's Nutrition, which is just a gender neutral package. The Regular Girl is very pink and girly, and not everybody is female in my practice. So sometimes we go with gender neutral. And then on Amazon, I found a partially hydrolyzed guar gum called Perfect Pass. and I thought it was funny, so that's why I recommend it. As you can see from my office, I find lots of humor in poop. So if it's funny, I'll recommend it. But it actually it has the same ingredients, so that's why I recommend it.
Thank you. Fantastic. So much to think about. Here we have a question from Jean asking, Beth, can you tell us what is involved with eating disorder training for dietitians?
That's a great question. So unfortunately, if you've been a registered dietitian in the US, you don't get much training on it. So you have to sort of seek out your own. Right now, what exists is a great organization called EDRD Pro. It's a subscription based group where you can watch webinars and get training. It's a great place to start. I'm going to do a little self-promotion here. I'm part of a group that's founded something called EDGI Training. It's EDGI Training, where we've created a training program for dietitians that want to learn how to treat eating disorders and GI disorders and the co-occurrence of both. And where else can you learn? I would say, finding weight-inclusive eating disorder dietitians who have specialty in eating disorders. So they might have behind their name CEDS. It's Certified Eating Disorder Specialist -S. So they're able to supervise. If you wanted to go through that process of becoming certified, you'd have to find a supervisor. I believe if you go on the IADEP website, IADEP website, I forgot what it stands for, you can find some of those folks there.
Great, thank you. That's really helpful to know. There are great resources out there. We have another question here from Laurel saying, can you speak a little more on Motegrity and Linzess? I'm not quite sure what from angle, but maybe, your experiences on how.
They're prescribed medications that a physician prescribes. Motegrity is a prokinetic drug that helps with motility, and Linzess is a drug that helps with constipation. I don't know exactly the mechanisms, but that's what they're used for.
Thank you. And then I'm just looking at our comment section as well. We have more appreciation of the poop humor. And Jessica also recommends many dietitians do fellowships with ED specialists as part of their training. So that's one thing to possibly look into. We have another question here asking, are you familiar with the GI map test? And if so, do you recommend it?
I am familiar with it, and I do not recommend it. I think at some point it's going to be a fabulous tool because it gives information about the microbiome, but we don't have enough information on the microbiome to be able to take that information and put it to work. So for instance, like the genome project that happened years ago, where all of our genetics are mapped out. If you were to find a gene, you would know what it was for and how it worked. We don't know all that about the microbiome. We might know the microbes themselves, but we don't know how they interact. We don't know if one uses the metabolite of another one. So we're not sure yet of all of that. I think over time, that might be a tool that's helpful, or there might be other tools that are helpful, but it's not something that I currently use with my clients. And I think, again, with clients with disordered eating or eating disorders, giving them more information that's not steeped in research yet can lead to more restriction if they think that they can fix something with food. We can't always fix something with food, unfortunately.
Thank you. Here we have another question starting with, do you recommend stool cultures to rule out food poisoning?
Yeah, sure. I don't do them. I'm not a doctor, so I refer to the gastroenterologist, and typically I do that a lot if somebody comes to me without a diagnosis. I want them to rule out all of the scary stuff first. So I want them to rule out anything that's structural before I'll treat it as a functional GI disorder. So yeah, stool cultures are important. I myself had C. diff and wasn't diagnosed with it because I didn't get a stool test right away until I ended up in the ER. So I think it's important for doctors to order them when patients come in and share their experiences.
Great, thank you. And then here we have one more on Nerva, really around kind of contraindication. So are there any times the Nerva app isn't recommended or isn't safe?
Yeah, it is contraindicated for any patients with psychosis. So that would be the major contraindication. And then really patients that have severe psychological comorbidities are often better fit for working with in-person therapists than just app-based care with Nerva. Sometimes Nerva can go alongside in-person care as well. But really, the two big ones are patients with psychosis, and then as well as patients with any severe psychological comorbidity that really should be seeing in-person care.
Thank you. Yeah, great to know about. And I'm seeing no more questions in our Q&A, and we are at the top of the hour. So really, Beth, thank you so much for your time. Thank you all for joining. I hope you found a lot of value in this session. I know I certainly did. And we will be following up with the recording and the CEU certificate. So have a good evening or morning wherever you're joining us from. Bye, everyone.
Bye, thank you.